welcome everybody. I'm glad that we have good attendance, and I hope I make you a little wiser after the end of the webinar. So for those of you who attended my previous webinar on glaucoma diagnosis, this is an extension of that webinar. And for those of you who are joining today, I hope you gain some pearls about medical management of glaucoma. So we talked about this, that actually what is happening in glaucoma is that the pressure is rising. The aqueous production per se is not increasing, but there is a problem in the drain. So there is a problem in the outflow of the aqueous, and that's what we try to address. We adjust the faucet and we open the drain. So there are three categories of drugs which work on reducing the aqueous humor production, and there is another category of drug which works on the outflow. So basically we will be addressing these different categories of drugs. Now from 1877 to 2017, if you see, for a very long time we had just very limited gamut of drugs, and it was only after 1955 that we rolled out a lot of drugs which are now being used clinically. So the last few years has seen a boom of drugs, and these drugs are effective in addressing the problem of elevated intraocular pressure. It's very easy to pick up your pen and prescribe a drug, but remember that once you prescribe a drug for glaucoma, it is for lifetime. Just like hypertension and diabetes mellitus, medication for glaucoma will just go when we leave this world. So we have to be very particular when we write a prescription for a glaucoma patient. Before we do that, it's very important that we ask relevant history related to systems. So whether they are asthmatic, whether they have COPD, because then we cannot give them beta blockers, whether they have a heart block or hyperlipidemia or hypertension, diabetes, again, beta blockers are a no-no here. If they have any depression, any urinary stones, arthritis, or any drug allergies. So all these will help you to craft your prescription properly. Any past history of trauma, history of steroid use, any previous glaucoma medications which the patient is using, any history of any ocular laser, family history of glaucoma, whether they can afford the drugs that you prescribe, how is their compliance? If we have a very elderly patient and the patient's children, they work throughout the day and there is no caretaker at home, she's likely to miss her medications. So you have to craft your drugs like that she takes a drug in the morning and at evening when the kids return. So an afternoon dose can be skipped out. So even these small things can help you craft your prescription properly. And steroid use, as I mentioned, is very, very important because we have a category of steroid-induced glaucoma. So you need to recognize that entity by taking history of steroids in any form, be it an inhaler, be it an ointment, or oral medications or intraarticular steroid injections. So knowing that is very important. So the first drugs that we would prefer to use are prostaglandin analogs or beta blockers. If the patient can afford the medication, then the first choice would be prostaglandin analogs. And unfortunately, if they are not able to afford it, then beta blockers becomes the first choice. Now, if the patient's intraocular pressure is getting reduced and they are tolerating the drugs, we let them continue these medications and keep calling them periodically and check their intraocular pressure, look at their optic disc, repeat the visual fields and OCT, and see if the drugs are causing any discomfort or are they okay with the drugs. But if the target pressure is not reached with the medication that we have prescribed, we see what is the percentage reduction of pressure that has happened from the baseline. So if the pressure is getting reduced by more than 15%, but still we have not achieved the target intraocular pressure that we wanted, that means that this drug needs some help and we add a drug to it. But if it has achieved less than 15% from baseline, that means it's actually not worth it giving it any further. Or if it is not well tolerated by patient, again, the patient is not going to be compliant. So we switch the drugs. So remember, 15% from baseline is the score that you want to keep in your mind when you want to decide whether you want to add or switch. Now, then you add another drug. If it works, well and good. If it doesn't, you decide whether you want to substitute the second drug with the third one or you want to add a third drug. And even if after adding a third drug, it doesn't really work, you consider laser or you consider a surgical option. Excuse me. So let's have a look at the first category of drugs, that is prostaglandins. Now remember, there are prostaglandin receptors throughout the body. It's not just the eye. There are two receptors which are particularly seen in the eye, that is PGFP and PGE. And they are located at the Schlemm canals and trabeculum meshwork. So here you can get an MCQ question in which they can give you a set of receptors and they can ask you which of these prostaglandin receptors are seen in the eye. So PGFP and PGE. The prostaglandins are further subclassified as prostanoids, prostamides, and docosanoids. So letinoprost, travoprost, tafluoprost, letinoprostine, all these, which are the most commonly used drugs, are prostanoids. Only bimatoprost is a prostamide. So again, you can get an MCQ wherein they give you the four options: letinoprost, travoprost, bimatoprost, and tafluoprost, and they ask you which out of these is a prostamide. So your answer would be bimatoprost. Uniproston is not available in India. It's available only in Japan, and it is a docosanoid. It's important to understand the mechanism of action of the drug that you're giving. So essentially, what are prostaglandin analogs doing after getting absorbed in the cornea? They are actually there in a prodrug form. They're an enzyme, esterase. It hydrolyzes the prodrug and changes it into a biologically active acid form, which then increases the uveoscleral non-conventional outflow. So the aqueous outflow is increased by giving these drugs. Now there is a new drug called letinoprostine which has been added in the armamentarium of the ophthalmologist. In addition to the this FP receptor pathway, it also has a nitric oxide mediated pathway. So this also can come as an MCQ question. So they will say which of the prostaglandin analogs works through the nitric oxide mediated pathway, and the answer would be letinoprostine. The efficacy of these drugs is maximum at bedtime, and therefore they are instilled at bedtime. They decrease the intraocular pressure by 25 to 32%. Their action lasts for over 24 hours, and it starts within 3 to 4 hours. And the maximum effect is brought about at 8 to 12 hours. Out of these drugs, tafluoprost is the most rapid acting. Now, we always tell our patient to relate instillation of eye drops with a bedtime activity, whether they brush at bedtime or if they are reading a book at bedtime. They should remember to put their drug every day because compliance is the key to success of treatment. These drugs are not without a set of adverse effects. So we need to have a proactive discussion with the patient as regards the cosmesis. Initially, when the medication is started, it causes conjunctival hyperemia. So these patients usually have some amount of redness after starting the drug. This hyperemia or redness usually goes away after a month. The drug is given at bedtime. So by the time the patient gets up in the morning, the redness is usually reduced. Out of the drugs that are available, bimatoprost has the worst hyperemic profile. So you can get a question, which prostaglandin causes most hyperemia? The answer to that would be bimatoprost. We should avoid using these drugs in unilateral glaucoma patients. One, they cause redness. Second, they cause excessive lengthening of eyelashes, and they also cause pigmentation of the skin around the eye. So if you are giving it to a person who has unilateral glaucoma, that means the person is putting the drug in one eye, then they're going to end up like a panda with one clear eye and one black eye. So a complete no-no for somebody with unilateral glaucoma. As I mentioned, they cause hyperpigmentation of the skin. They sometimes cause excoriasis of the skin also, excoriation of the skin also, lengthening of eyelashes. Sometimes vellus hair, they grow around the eyes because of this. And letinoprost has been shown to cause more hyperpigmentation vis-a-vis bimatoprost. Why is this pigmentation happening? It's happening because of the increased activity of an enzyme, which is tyrosine kinase. So remember, if you get a question in which the patient has lengthening of eyelashes, periocular pigmentation, deepening of the superior sulcus, the answer to that would be, and they ask you which drug the patient is taking, the answer to that would be a prostaglandin analog. Another big category is that of adrenergic receptors. We have both antagonists and agonists. So out of these, the ones that are really helpful to us are the beta receptors and the alpha receptors. Now the alpha 2 receptors on the ciliary epithelium, they decrease the production of aqueous humor. The beta 2 ones, they decrease the resistance. Otherwise, on ciliary muscle, we also have these beta receptors which causes relaxation of far vision. So remember, we need alpha agonists and we need beta blockers. Then only we will have a reduced aqueous production. So amongst beta blockers, we have non-selective ones, which include timolol, levobunolol, metoprolol, and selective ones include bitoxolol. For patients for whom you have to give timolol, you have to give a beta blocker, but they have coexisting respiratory or cardiac issues. In those, bitoxolol was considered to be safer. But otherwise, with newer timolol, which is to be instilled only once, even timolol can be given, unless there is a battery of contraindications, which we would be discussing subsequently. Now, these drugs also lower the intraocular pressure by 20 to 30%. They are also given twice a day. They have two phenomena associated with them. One is the short-term escape and the other is the long-term drift. What do we mean by short-term escape? Initially, the response is very good, even to the tune of 40% sometimes. But after instilling over a few weeks, the response blunts down and the IOP reduction is somewhere around just 15 to 20%. Long-term drift refers to after 1 week of treatment, the aqueous production does reduce by 40 to 50%, but it remains only to about 20 to 25% after 1 year. So if the response subdues in a few weeks, it is short-term escape. If the response subdues after a year of using beta blockers, it is called as long-term drift. How do these act? They inhibit cyclic AMP in the ciliary epithelium and thus they decrease the aqueous production. So remember, 3 categories of drugs which reduce aqueous production: A, B, C. A is alpha agonist, B is beta blockers, and C is carbonic anhydrase inhibitors. Look at the battery of adverse effects these drugs have. On cardiovascular system, they run a havoc. You can have bradycardia, heart failure, decreased arterioventricular conduction, cold feet and hands, postural hypertension. They can even worsen the peripheral vascular diseases. They also cause worsening of chronic obstructive pulmonary disease and asthma. It can precipitate asthma. They cause sleep disturbances in elderly people and depression. And that's something we usually don't tell our patients that, we are starting you on beta blockers, but they can cause mood swings and depression. And in young males, if we give beta blockers, it can even cause decreased libido. So that can exacerbate depression. So these are things that we usually forget to tell our patients, but they make a huge difference in their life. Also remember that brimonidine and carbonic anhydrase inhibitors are a relatively safer alternative to beta blockers in geriatric patients, because usually geriatric patients have a lot of cardiovascular issues, so you want to stay away from beta blockers. The contraindications, as I mentioned, would be somebody with an overt cardiac failure, a cardiogenic shock, AV block, bradycardia, reactive airway disease like asthma, or presence or history of severe COPD. Now, somebody who's taking oral beta blockers for their hypertension, giving topical beta blockers to them is going to have an additive effect, and you want to stay away from that. If somebody has a deranged lipid profile, we must start them on statins and avoid beta blockers, because it is not really good for the lipidemic status of the patient. Remember, beta blockers mask symptoms of diabetic-related hypoglycemia. So if somebody is an uncontrolled diabetic or has significant amount of deranged HbA1c and you're giving them beta blockers, they will have impaired glucose tolerance, so you want to avoid giving this drug. Beta blockers can also mask symptoms of thyrotoxicosis. They can cause lethargy and confusion in newborns, and they are actively secreted in breast milk, so they are to be avoided in lactation. So this needs to be remembered. Coming to the next class of adrenergic drugs is alpha agonists. So non-selective and selective. The non-selective ones are not used at all in the current day and age. What we use is apraclonidine and brimonidine. Even apraclonidine is falling out of use. Brimonidine is the most commonly used alpha agonist. It is given in the dosage of thrice a day as a fixed drug combination. Now, what do we mean by fixed drug combination? That in one bottle, you have two drugs. So usually you can have brimonidine along with timolol. So one bottle will have both the drugs. In a fixed drug combination bottle, the dosage becomes twice a day. It results in a decrease of IOP by 20 to 30% from the baseline value. It reduces intraocular pressure after 1 hour of instillation. Now, brimonidine, it also works by decreasing in the cyclic AMP. It also decreases episcleral venous pressure and increases uveoscleral outflow. So here, remember, I told you that alpha agonists reduce aqueous production, but they also increase uveoscleral outflow. So if you get a question, which anti-glaucoma drug has a dual action, then remember that brimonidine is the answer, because it decreases aqueous production as well as increases uveoscleral outflow. But brimonidine is notorious for its adverse effects. Look at the kind of skin this patient has now got after just 1 week of instillation of brimonidine, and there is so much of crusting at the base of eyelashes. So the drug allergy is very common. We get follicular conjunctivitis, periocular contact dermatitis. The entire skin is as if something has burnt the skin. So there is contact dermatitis. Some patients have lid retraction also. Systemically, it causes drowsiness. So we avoid giving brimonidine to people who work around heavy machinery like in factories, because since the dosage is 3 times a day, when they put the drug in the morning or in the afternoon, they can become drowsy and they can have accidents. Similarly, for long distance drivers, we avoid giving the drug for the same reason. It's not given in children less than 6 years and 20 kgs in weight, because it crosses the blood-brain barrier and can lead to apnea and cyanosis and sometimes even coma. So this can come as an MCQ question. Contraindication: which drug is contraindicated in children? So the answer would be, I'm sorry, the slide is slightly fuzzled up. Category, which is carbonic anhydrase inhibitors. We have oral as well as topical. The oral ones include acetazolamide, methazolamide, ethoxazolamide, which is not available in India. The topical ones include dorzolamide and brinzolamide. So wherever you have a mide, Remember, it is a carbonic anhydrase inhibitor. They decrease the aqueous production, and the mean reduction from the baseline is usually 20%. Just like alpha agonist, 3 times is the dosage if they are given alone, but if they are in a fixed drug combination with timolol, then it is given twice a day. A set of precautions to be taken even with carbonic anhydrase inhibitors. Since brinzolamide comes as a suspension, we should always tell the patient to shake it before use. Otherwise, patient can have some precipitates deposit on the cornea. It is avoided in patients who have just gotten a recent corneal transplant because it leads to decompensation of the donor cornea which the patient has received. So the question can come that we have a patient who has high pressures after a corneal transplant. Which of the following drugs should not be given? So remember to choose topical carbonic anhydrase inhibitor, either brinzolamide or dorzolamide, as your answer. They are also to be avoided in patients who are allergic to sulfonamides. They have drug interaction with diuretics. They lead to volume depletion and significant hypokalemia. So remember to exercise caution when you are giving it with both diuretics or aspirin. Then comes another class of drugs, which is a miotic, that is a pilocarpine. Pilocarpine is primarily now given just before doing a laser iridotomy for a patient with angle closure glaucoma. In open angle glaucoma, now we have a good set of drugs that we talked about that we use much prior before using pilocarpine. So how does it work? In angle closure glaucoma, it causes miosis, that is constriction of the pupil. The pupillary sphincter constricts. There is pull and tugging of the iris. That leads to pulling the iris away from the angle. The volume of the iris tissue decreases in the angle, and the peripheral iris is pulled away from the trabecular meshwork, which opens up a little bit, and the aqueous gets a passage for the outflow. So usually doing a laser iridotomy, it causes a relief, an additional pathway for the aqueous to flow out. And before doing a laser iridotomy, we use pilocarpine. In open angle glaucoma patients, it stimulates the ciliary muscle. It causes a tug or a traction on the scleral spur. The trabecular sheets get opened up, they get separated. The sheets that were collapsed earlier now open up, and that allows the aqueous to find a way to flow out. Now, the response of pilocarpine, it depends upon the color of the iris of the patient. Now, Indians usually have brown iris, and usually we have much darker irises compared to other races. So we show a good response to pilocarpine. Now, this is a pilocarpinized eye. Look at the pupil, it is so myosed. And after causing meiosis with pilocarpine, a laser iridotomy has been done in this patient with angle closure. As I mentioned earlier, it is given pre-laser iridotomy. Initial therapy for pigmentary and pseudoexfoliation glaucoma can also be given. The adverse effects are that it causes so much of spasm over the brows. So brow ache is very common in young individuals because it induces near accommodation. Therefore, we avoid giving pilocarpine in individuals where accommodation is already very active. So in young individuals, we don't give pilocarpine. It leads to orbicularis muscle spasm. It also causes redness. It causes inflammation. It can even result in cataract, iris pigment epithelial cysts. It can lead to retinal detachment and retinal hole formation in myopic eyes who have angle closure. And sometimes, in some cases, even vitreous hemorrhage has been reported. These were the topical drugs. Now somebody comes to you with 60 or 70 pressures. All these medicines are not going to be of any use. Why? Because to act, medicines have to be absorbed in the blood vessels which are there in the iris tissue. Now, iris tissue is already so much under pressure because of the pressure that is being there from within the eye. So 60-70 pressure, the entire vasculature would be collapsed in the iris tissue. So to make the blood flow again in the iris, you want the pressure to come down. Now, it is very difficult for even acetazolamide to bring down the pressure fast. So we give mannitol or glycerol, which is a hyperosmotic agent in these cases. Now, what it does is that it increases the osmolality of plasma. There is a gradient that is created between blood and vitreous, and water is drawn out from the vitreous into the circulation. So basically, dehydration of the vitreous. Now, vitreous is there in the posterior cavity of the eyeball. The moment vitreous dehydrates, the iris falls back and the passage in the angle opens up for the aqueous to flow out. So mannitol is the safer of the hyperosmotic agents. Why? Because it does not increase the blood sugar level, just like glycerol. So glycerol, we have to know the diabetic status of a patient before we give glycerol to them. Mannitol, we don't have this problem. So mannitol you can safely give to anybody, even if you don't know the fact that they're diabetic or not. Remember, the key word here is vitreous dehydration. Once vitreous gets hydrated, the pressures go down, the steamy cornea, it clears up, and then you can start your topical medications, which will then be absorbed by the iris blood vessel and start working. Mannitol is given IV. The duration of its effect is 6 hours. Pre-mannitol, it is very important to check the BP because you don't want to cause a fluid overload by giving 300 cc of mannitol. Now, sometimes there can be crystal formation, as you see here in this bottle, in patients who are given mannitol. So you have to be cautious when you put up the bottle to see whether there are any crystals. If there are, discard this and get a fresh bottle. So crystal formation is a contraindication of using a mannitol bottle. Glycerol is extremely sweet. So it makes the patients nauseous when they are having this drug. So we always give it with ice and lime water. The ice cuts down the sweetness of glycerol. It has a short-lived effect. It is given 1.5 to 3 ml per kg of 50% solution. So essentially the patient has to take about 6 TSF of glycerol 3 times a day. So 18 teaspoons of something that sweet can be very toxic. So sometimes patients don't even take it properly. It's just a temporary measure till the time you plan the patient up for a surgery. As I mentioned earlier, it is contraindicated in diabetics. Now, these drugs, just like all other drugs, have adverse effects. We talked about vitreous dehydration, but we are giving the drug systemically. So the drug is acting everywhere and causing dehydration everywhere. It also causes cerebral dehydration, and that results in headaches. It causes increased diuresis. So urinary retention can be there in patients who have BPH, benign prostatic hypertrophy, and these patients can find it inconvenient to take hyperosmotic agents. Renal failure is also a relative contraindication for this group of drugs. Now, you can get a question: which drug of anti-glaucoma drugs is safer in patients who are pregnant? Now, pregnancy is a physiological state where essentially, even for a glaucoma patient, the intraocular pressure becomes low. But if you have a pregnant patient who is glaucoma patient and has high pressures, then in the first and second trimester, remember 2 Bs, brimonidine and brinzolamide. They are the safer drugs, first line and second line in first and second trimester. But in late pregnancy and lactation, brimonidine is a complete no-no. You need to give either pilocarpine or brinzolamide. And second line drugs, you can consider prostaglandins also during late pregnancy and lactation. There is a classification for assessing safety of medications. I'm not going into details of that. You can just dig out. There is an FDA drug risk category. But remember 2 Bs, brimonidine and brinzolamide, first and second trimester. These can be safely given in pregnant patients. Now you can be asked a question about double dot technique. Now after somebody has put an eye drop, the eye drop will go and pass through the nasolacrimal duct and out. So in order for better retention of the drug, tell the patient to close their eye, not to open their eye for 5 minutes after instilling of drugs, and do digital occlusion of the tear duct. So they press their tear duct with their fingers so that the drug is absorbed and it does not drain out into the systemic circulation. This is called as a double dot technique. It minimizes the systemic side effects of different eye drops. Now, this was about medical treatment. Let's come to laser treatment. Now, lasers for open angle glaucoma and closed angle glaucoma are different. For open angle glaucoma, what we do is a selective laser trabeculoplasty or SLT. For angle closure glaucoma, we do laser iridotomy or laser iridoplasty. Iridotomy is the most commonly performed procedure, so I will be talking about that. When do we consider this? When the primary treatment is, when the patient does not want to be put on medications and you think that a laser can safely work for them. When the target pressure is not achieved with just medical therapy, then you add on laser to the medical therapy. And when the patient is absolutely non-compliant of medical therapy. For example, I have a patient with early glaucoma. That patient is a busy person in, say, some IT world. And throughout the day, they're busy with their work and they forget to put their medications. So I can safely do a selective laser trabeculoplasty for them. It will buy them 2 or 3 years of drug-free period in which I can monitor them from time to time and see whether the disease is progressing or not. Now, SLT usually does not work beyond 2 to 3 years, so we have to start treatment after that. Coming over to laser for angle closure, which is laser iridotomy. So if you see, this patient has come with an acute attack of angle closure glaucoma. Telltale signs are the congestion, the redness of the eye, mid-dilated pupil, shallow angles. So what is happening here is that the aqueous is not able to drain out through the angle. It is collecting behind the iris and giving a push to the iris. So if we do laser iridotomy, we create a hole in the iris. Then this fluid which is collecting behind the iris finds a passage to go out and drain in the system. So laser iridotomy actually creates an equilibrium between the anterior and the posterior chamber by redistribution of the aqueous. So this is just a small video to show what happens in laser iridotomy. So you need to focus here between the reticule. We usually focus in the area where there are crypts. So where there is a crypt, there the iris is relatively thinner and the laser energy to create a hole there would be much less as compared to a thicker area. This is the laser beam, the one with the red dot. It is being focused here. So I found a nice crypt. Using that laser beam, we will hit upon that area with the laser energy. You can see some bubbles coming out from there. A couple more shots and we will have a hole at that place. See, the aqueous and some pigments are coming out from the hole that we have created. The adequate size of a laser iridotomy is about 150 microns. Can you see the flow of aqueous from behind and some pigments? And here we have a nice laser iridotomy created in a crypt area. A plume of pigments comes out from this place. So that was laser iridotomy done for angle closure patients. Now what if medications or laser alone or a combination of medication and laser is not working? The pressures remain high and the patient is almost going to go blind because of high pressure. So in those cases, we need to consider surgery. Whenever you are faced with such a problem, you have 2 decisions to make: to perform or not to perform surgery. And the second decision is what type of surgery to perform and when to operate. When to decide for surgery? Remember, the risk of vision loss without the surgery should be much more than risk of vision loss with surgery. So if the patient has very advanced glaucoma, if you don't do anything, anyway, he's going to go blind in a few months. You might as well go and do the surgery. The chances of preserving the vision, whatever little vision is left in those cases, would be way more than just letting them go without the surgery. Surgery is also indicated in advanced cases when you know that the patient is not going to come back to you and they are non-compliant with medical therapy. So we have patients who come from villages. They are not going to come back to a tertiary care center repeatedly for a regular follow-up. They sometimes don't get access to the medical therapy, and even if they have access, sometimes they don't have the money to buy medical therapy. In those cases, we should take the decision of operating for glaucoma much earlier. So we have two options. One is filtration surgery and the other one is the drainage device implantation. So the common filtration surgery which is done for glaucoma is trabeculectomy with or without antifibrotic agents. So we can have two antifibrotic agents if we use mitomycin C or 5-fluorouracil. So what is happening in a trabeculectomy is that we are creating a passage through which the aqueous can flow out. So we cut a block of trabecular meshwork, we do an iridotomy in the same area, and then the aqueous, it kind of flows out through this cut block and it goes underneath the conjunctiva to create an elevation or a blister-like bleb, as you can see here. And through here, there is a transconjunctival absorption of the aqueous. The next surgery, I'll show you a very quick abbreviated trabeculectomy. So we put a suture, we do some dissection in the conjunctiva, make a scleral flap, we cut a block of the trabecular meshwork. Now we are cutting a little bit of iris. Then we suture the scleral flap that we had created. This is tying one side of the triangular flap. Then we are suturing the other side of triangular flap. The aqueous would flow from the block that we had excised and it goes back into the conjunctival space. After suturing the scleral flaps, we suture the conjunctiva. So that's a very quick recap again of a trabeculectomy. Can you see here triangular scleral flap, a block of trabecular meshwork being cut, a little bit of iridotomy at that site, and the flaps being sutured. The next surgical option is aqueous drainage device. So you see that we have a device in which we have a long tube and a plate here. The tube is passed inside the anterior chamber. The aqueous goes from the anterior chamber via the tube into the plates, and then it is disposed of under the subtenon space, and from where it is absorbed. We have two types of implants, the ones with valve and the ones without valve. They are outside the scope of MBBS syllabus, so I won't go into detail, but you should know that there is an option of something like a tube which drains out the aqueous, and therefore it is called as a aqueous drainage device. Clinically, a patient with a device will have a tube put visible inside their anterior chamber. So that's how it will look like. So the take-home message is that eventually, by hook or crook, we have to reach our target pressures. The target pressures initially can be attained by medication, but there is a limit to giving medications because all medications have their adverse effects. So minimal medication is our goal. We want to maintain the quality of life of patient. We don't want to give them a red eye that they get so troubled and they don't put their medication. So you need to craft your medication according to each patient's needs. The medication should have a sustainable cost. It's no point writing expensive medications which the patient is not able to buy and they don't put their eye drops and they eventually turn blind. So you have to keep a note of that. Check the compliance from time to time. Compliance means whether they're putting their drops or not. No drugs will act if they're sitting in their bottle in a refrigerator and not entering into a patient's eye. Ask the patient proactively about adverse effects on each visit. And when it's time, consider surgery and laser timely. Remember, not just for glaucoma, for any disease. As to diseases, make a habit of two things: to help or at least to do no harm. So this was given by Hippocrates, and we need to really remember it has been tested across times that remember to do no harm. So you must ask the patient about adverse effects each time when you see them again, and don't write prescription without thinking. Ask history. Any new disease can come at any new time. If at the time of starting treatment we ask somebody about diabetes and they say no, it doesn't mean that after 2 years or 5 years they can't develop it. So history also has to be repeated and refreshed after a few months or at least once a year. With this, I would like to have a look at all the questions that you have posed to us, and will try and address them to the best of my capability. Yes, please summarize the sequence of drugs to be given. So, to somebody who can afford prostaglandin analogs, my first choice would be a prostaglandin analog. If it doesn't work and I want to add another drug, then I will give timolol. So if I give prostaglandin, then timolol I add. They are giving us separate bottles. Now, when I see that prostaglandin and timolol are working together very well, then I will shift them to a fixed drug combination. So prostaglandin I was giving once at bedtime. Timolol is given twice. So the patient is putting 3 drops. Now, when I make it into a combination of prostaglandin and timolol, it again needs to be put once. So the compliance will become better. Now the patient is on prostaglandin and timolol, but the pressures are a little towards higher side. I want to bring them down a little further. Then I would consider carbonic anhydrase inhibitor topical, that is dorzolamide or brinzolamide. Now, studies have shown that dorzolamide also improves the blood flow of the optic nerve. So this will be an additional feature that I would want to add on to. And if all goes well, perfect. If doesn't, and there is a little bit of elevated pressure, now I will add brinzolamide. After adding brinzolamide, if I see that it is perfect and it is getting the pressure that I want, there is a fixed drug combination of brimonidine and brinzolamide. So now I will club these two. So otherwise, brimonidine thrice, brinzolamide thrice will be 6 drops, and that will make it very difficult for somebody to remember. At least I will forget, and I'm sure many of you will also. So when we club it into a fixed dose combination, then it needs to be instilled just twice a day. So say, for example, if somebody is on 4 drugs, prostaglandin, timolol, brimonidine and brinzolamide, if I give them 2 fixed drug combinations, one with prostaglandin, timolol, 1 drop, one with brinzolamide and brimonidine, 2 drops. So they're getting 4 drugs in their eye with just 3 drop instillation. So that's how we craft a prescription, and that's the order I would like to go. Now, when I do a perimetry for such a patient and I see that there is advanced damage in glaucoma, I will tell them that, see, your disease is progressing. You are already on maximum medication. I think now we should consider a trabeculectomy. If the patient agrees, we go ahead with a trabeculectomy. If they don't and they want to buy some time, I will do a SLT for such a patient and try and bring down the pressure. That's usually how it works, but we have to tailor make our treatment for each patient individually. There's another question as to how much time we can prefer pharmacological medication before we go towards a surgery option. Gajanand, I think this is a very individual choice of the surgeon. Plus, it depends at what time the patient is coming to us. Say, for example, if the patient comes to me already with a very advanced disease and with so much of damage that has happened and with uncontrolled pressures, there is no point wasting more time. I would rather consider doing a surgery. And there are some patients who you detect as to having a glaucoma and you detect them timely, then you can keep them under observation. For some patients, the progress of the disease will not happen even for 10 years. And for some, the progression will be so fast that even within 10 months, you can have a progressive glaucoma. So it's very, very individual. And I don't think there is any cutoff time when you decide to just go ahead with the surgery. That comes with experience. Did cataract and glaucoma occur simultaneously? Yes, cataract and glaucoma can occur simultaneously because both these diseases are actually diseases of elderlies. So an elderly patient can have cataract, they can also have glaucoma, they can also have diabetes mellitus, and that can result in diabetic retinopathy. So much can happen at one point of time. Now, if somebody has a early glaucoma, which is managed with medication, and they also have cataract, I will just do a cataract surgery and let them continue with glaucoma drugs. If somebody has a moderately advanced glaucoma and a significant cataract, then I can do phacoemulsification for the cataract and trabeculectomy for the glaucoma in one sitting, and that procedure is called as phacotrabeculectomy. After this procedure also, some of the patients can require medications. So you can club the both surgeries together. Another question by Jawahar is that which drug possesses effective and lesser side effects in the treatment of glaucoma? I think the newer prostaglandin analogs, if they are given with some caution, are relatively safer. For example, if I tell the patient to put some sort of a moisturizer underneath their eye, then the prostaglandin drop will not touch the skin and the periocular pigmentation will be limited. Also, if the patient occludes their punctum after putting the drop, the systemic absorption will be less, and they can wipe their extra drug with a tissue paper. So that will also be less. For the redness part of it, if they know that it will reduce or go away in about a month of starting treatment, but the drug is very good for their glaucoma, they usually don't object. So I think I would still go with prostaglandin analogs. Snehal has a question that I have been suspected case of glaucoma for last 2 years. Doctor said that there is glaucoma, said no glaucoma. What will be the confirmation criteria? Snehal, I hope you don't get glaucoma. That's one wish for you. I think a fresh OCT for retinal nerve fiber layer thickness along with a perimetry 24-2 CETA standard. If both of them are normal, then you will not have glaucoma. Having said that, I would rather label you as a glaucoma suspect, and I would think that you should get at least 6 monthly or 1 yearly repeated checkup from your doctors. And if there is no change in the visual field or OCT RNFL, we can be safe to say that you were just a suspect and not having the disease. Dr. Bansod says that can we consider the use of ceton device in very advanced glaucoma cases? Yes, ceton devices are also another word for glaucoma drainage devices or aqueous drainage devices. They can be considered for advanced glaucoma cases. If the angles are shallow, then the tube of the ceton device can be put in the ciliary sulcus, or it can be put even in the vitreous cavity. But in open angle glaucoma cases, we put the tube in the anterior chamber. Yes, remember, glaucoma is a disease of asymmetry. So when you have symmetrically enlarged cups in a disc, that means there is physiological cupping, because if there is symmetry, it is unlikely to be glaucoma. And therefore, Snehal, I think physiological tilting of the disc would be your diagnosis, and I would rather say that you are an optic disc suspect rather than labeling you as a glaucoma. So that's what I could see. If anybody has any more questions, please pop in your questions. We still have some time. Also, I would like to know from any one of you, if you are liking the way I'm teaching, would you like anything to change? And if there are any other webinar topics that come to your mind, I would be happy to, address those first than what I would like to do. I also wanted to do a photography-based or an image-based webinar next time. So I'll show you a few images and then we'll ask questions based on that. And those are the images which are very characteristic of diseases and would probably help you in answering your questions in the NEET exam. We have another question by Nishtha, and she asks us, can a scar in sclera result in glaucoma? I don't really think that, unless it is associated with scleritis, and some patients of scleritis by virtue of inflammation can have glaucoma, but not a scar per se. So would need more information regarding that scar. Well, thank you. And I would, yes, okay. Sneha says that can we have a webinar on eye allergies? I think we can have one webinar on red eye, in which we can cover various causes of red eye, which includes allergic conjunctivitis, infective conjunctivitis, corneal ulcer, iridocyclitis, episcleritis, and that should address a lot of your concerns. Yes, Dr. Puthul, we will go on to a strabismus webinar. We are just building up the series. We'll probably take red eye next, and then with the strabismus. Sai has a question: what will be the effective treatment for pseudoexfoliation? Pseudoexfoliation is a very tricky glaucoma. Cataract surgery in a patient with pseudoexfoliation opens up the angles a little bit, and it does help in reduction of pressure. Once cataract surgery is done for such patients, then essentially the treatment is same as other primary open angle glaucoma cases. And if it is not working, then trabeculectomy works well for a pseudoexfoliation patient. I thank all the students who have asked questions, because it actually feels good that they paid attention to what I made an effort for. And I would like to do another webinar next time on red eye, which will address a lot of concerns related to common conditions with similar presentation. So thank you, everybody.